Welcome back to Dr. Kall. We are going to discuss knee replacement surgery and the various techniques that are used to help us in knee surgery. These are instrumented, robotic, and PSI, which is a patient-specific implant, CT, MRI driven. So, first of all, the instrumented is a traditional one. Here we're using mechanical instruments, rods, guides, saw blades, all these things to actually do your knee replacement. It's the way we've always done it, and it very much dependent on your surgeon's hands and eyes and experience. You certainly want to make sure that you have an experienced surgeon to help you with the knee replacement. So the incision is about the same in all three ways, in all three methods. But on the instrumented, we're actually putting a rod up your femur, so that may be a little bit more invasive in terms of your bone, but not really in terms of your incision. But there's an extramedullary rod, so a rod outside your lower leg, and it's very dependent on the surgeon's eyes and hands to get your alignment and to make the cuts. So you want an experienced surgeon, and it's fast, it's reproducible, it's quick, and it works. So PSI is the other one. It's CT, MRI driven. Here you get a CT ahead of time and an MRI ahead of time, and your surgeon on a computer actually plans the surgery. So the surgery is planned. You can see with the CT and MRI, you can see parts that you really can't see with just the open incision. So you can see behind the soft tissues, you can see behind the bone, and you can see the center of the hip and the center of the ankle, and it helps you with the alignment. So the idea is we're using technology to narrow the bell curve and make it so that it's a little more accurate. It's perhaps a little less invasive than the instrument because we're not making a hole in the intermediary canal, but it is dependent on these plastic molds that are patient specific. In other words, they're made just for you, and it usually takes about 6 weeks for the manufacturer to actually make those and get them back to us. So there's maybe some delay in your surgery. The other problem is that many of the commercial insurers will not cover CTs or MRIs for surgical guidance, which is unfortunate because the CT and MRI improve your surgeon's ability to make decisions and to decide on where to put these things. The third method is the robotic, and with the robotic, again, some of the robots use CTs and X-rays in order to do this, but you can do it without those as well. And again, when you run into the trouble of insurers not covering this, but with the robot, the robot's very precise, and it is a machine that the surgeon directs. People think that I'm in my office with some joysticks doing this. Well, not true at all. I'm in the OR, and the robot actually takes more time because you're doing the planning and you're doing the execution of your plan on the fly in the operating theater. So the robot's advantage and disadvantage is that it's on the fly, but it also takes more time. You have to put 2 pins in the thigh bone and 2 pins in the shin bone. And then you have to hook up these antennae, and the robot has to recognize these, and then the robot has to know where in space things are to help you make those decisions. So again, you're doing all that planning while the patient's asleep and while the incision is open. So this takes longer. It just does take longer. There's no way to actually make it shorter, although people do get better and better at this, and can become quite efficient at it. It still takes more time than your traditional instrumented or your PSI. So the whole idea of the robot is to make it precise. It is to make it so that we're using technology again to narrow the bell curve. The disadvantages are pin site infections and fracture perhaps from the pin sites, and also the chance of infection in these areas. The advantage is that it's precise and it helps you do what you need to do, and it does it very well.